There you go.
It's official. We're on.
Hello.
Welcome, everybody. We've got several people already on. We'll wait just a few more minutes here as we're getting more and more people coming on. But, hello to everyone so far.
Hi. Thanks for joining.
I'm excited about all this. Are you?
Me too, although it's funny, right? When we don't have the feedback of the audience. Usually there's someone sitting in front of us.
I don't know.
Can you see us?
The podcast is kind of that
It
way.
sounds like the answer
you
is
can't
maybe
see me?
no. Do you need to do anything down here?
Oh,
Christy says yes, she can.
Christy can see. Are you sure you want to start sharing?
I don't know.
I don't think it's that. No, that's sharing the screen.
Okay.
Christy can see me.
All right. Looks like some people say yay and some say nay. Okay. Well, hello. What are we talking about today?
Well, you were just saying about, I don't know, I think we're kind of used to talking
Yeah,
to
well,
sort of
I
no
realize
one,
when
even
people
though-
send the chats,
Yeah,
that's kind of interactive. So
yes,
that's nice.
That is helpful. Yeah, hi, Christy. But we started this podcast, and I guess that's kind of, we're sort of just talking to one another, I guess. So now we're just going to have a conversation, and hopefully everybody gets a chance to learn a little bit more about hormones and certainly a little bit more about yourself. And I'm just going to go ahead and get started.
Yep.
Here's what you're going to learn today. You're going to learn who we are, and we'll talk about that in a second. And we're also going to talk about, well, that's okay. I'm getting some help here. Oh, okay.
Thank you.
Thank you.
What you're not going to learn is IT. That you're not going to learn.
And I'm not going to learn that from me. We might learn it from Saber here, who just kind of snuck over and helped us out. Why your hormones relate to how you feel. Definitely how it all interacts with one another, because there is a synergy that goes on with all of them. And then what treatment specifically for you can help to correct whatever's going on with you. And then specifically from there, where can you get help? And there's a lot of options with that.
And I just want to point out this idea of how the hormones interact and the idea of treatments. One of the things that you will get from joining along with Dr. Robinson and myself is you will continue to understand what probably instinctually you already know, which is the interrelationship of your body and all the different parts. So not separating you into a cardiology patient, an endocrinology patient, a gynecology patient, et cetera, but just reminding us that the body really does work as a whole.
Great point. We always say we are married to each other.
To each other.
We always have to kind of start off with that. My name is Dr. John Robinson.
And I'm Dr. Christina Bosch.
So obviously different last names. So every once in a while, people, I don't know how they gather that. We're usually on top of each other when we're talking, but sometimes people don't realize that we are in fact married and have been so now we just celebrated 12 years.
Yep.
You can also follow us on the Sex Docs. This is something that we've been focusing on for a lot of years with what we do as physicians, focusing on hormone replacement therapy, but inevitably sexual wellness. It's a really big part of what we do. You can now also follow us on the Longevity Protocol, which is a podcast that was also recently launched. I think tomorrow is the fourth or fifth episode.
The fifth
episode coming out.
Brand new.
So still very new, having a lot of fun with that.
Yeah.
Same thing, a lot of discussions about hormone replacement therapy, but really just overall wellness and how it relates to marriage and sexual wellness and all kinds of fun things, all weight loss and all things
intimacy
and how that all affects your ability to live the longest, best life you possibly can. So follow us there on the Longevity Protocol, Spotify, everything else. We are all over the place at this point.
Like in a good way.
Yeah, right. In a good way, right? Not scattered to the winds. This is the various locations where you can come and see us and meet us, or in some cases, many of the cases, meet the fantastic physicians that we have either been associated with or personally trained.
Right.
So here we are in Scottsdale, Arizona at the moment. We do have our main private practice in Scottsdale. We also have another practice called Skin Restoration in Prescott, Arizona, that is evolving into an actual hormone zone med spa. We're also in Livermore, California, which is the East Bay. This is a fantastic med spa that is over there. Really, really fantastic people there in Livermore.
And I'm sorry to interrupt, but even though you say med spa, we do HRT, we do hormone replacement therapy at all of these locations.
Yeah, it's medical aesthetics and wellness.
Right. Medical aesthetics and wellness is much better.
That's the way we look at it,
Yeah.
because it is very advanced on how we're approaching everything. It is from a medical standpoint, and it's a holistic, comprehensive approach to aesthetics as well, because we're inevitably putting all of the hormones and the and nutritional considerations,
Right.
all these things together from a longevity standpoint to help you from the inside and the out.
For more graceful aging,
Absolutely.
beautiful aging, etc.
And that would be the same thing there in good old Orlando. Hi, all you Affinity people out there. Fantastic people in Orlando. And Affinity is also extremely comprehensive in its approach as not just a medical aesthetic med spa, but also wellness and chiropractic. And it's just a very comprehensive approach to overall longevity and health. And then, of course, our men's clinics in both Oklahoma City and in Tulsa. Absolutely love going out there, love working with the guys out there. And we also say, too, that it's not just for the Oklahoma men, but it's also for the women who love them. So even though these are men's clinics, we serve women there as well to be able to help. We say it takes two to tango. So know that your partners are also handled there just as much as the guys are. And that's hormone replacement therapy, a lot of sexual wellness, of course, that we're handling there at the men's clinics.
Right.
Someone is going to win this fantastic raffle. So we will announce this later. Some lucky person is going to get an email regarding who won this fantastic package. It's $1,000 package that you would then get $500 off of, making it only $500 for that package. So fantastic opportunity for everyone who's attending. Now,
Right.
This is what we're going to go over. And this is an overview. I want to make sure I'm leaving some time for question and answer, but know that this is a general overview about hormones. This is definitely the overall interplay between all those hormones. So we have sex hormones. That means your gender-based hormones, estrogen and testosterone. Thyroid, our unique approach to that. Insulin, digestion, that would be blood sugar control and weight loss. Adrenals, and your stress hormones, DHEA, cortisol, adrenaline. And then growth hormone kind of as that linchpin that holds it all together, that is the quintessential longevity anti-aging hormone. Let's start with thyroid. And this is actually about change. The word metabolism actually means to change. And we've developed over the years a really distinct system of how to approach not just the diagnosis, but the treatment of thyroid issues, mostly low or hypothyroidism. Here's some of the symptoms, and there's a lot. We call the thyroid the great pretender, right?
You can blame everything on the thyroid.
Pretty much.
I mean, I pretty much blame everything on the thyroid. We start with that premise. And then, of course, if it's not giving us the maximum results that we're looking for, then what's so great about the previous slide is that it gives you a sense of how we as physicians and our fellow physicians and our team will say, okay, well, what else do we need to do? But we always start with the thyroid.
Yeah, for sure. And you can see here just some of the general things: constipation, anxiety, fatigue for sure. It can be weight gain, but interestingly, a lot of people will have fatigue and low thyroid and don't necessarily gain weight. It isn't always that way. But these are the usual suspects. This is a book that sort of codified our unique system that we call Thyrazone. We've been doing this now in some form for probably about 18 years now, and it's had its iterations over the years, and we've really solidified and then figured it out at this point of how to really uniquely handle it.
Mm-hmm.
So for those people who think that they probably think it's a thyroid issue, but a regular doctor has not figured it out, your regular conventional primary care has not figured it out, there probably is an answer for you.
Or you're already on thyroid treatment, but you still don't feel great. And the doctor says, well, your labs look good.
Right.
And then we always say, okay, but you don't feel well. That's a very important piece of the puzzle.
Yeah. No, there's answers for
Mm-hmm.
you. So adrenals, this is small little glands that sit on top of your kidneys, and they secrete adrenaline, adrenaline, and cortisol and DHEA, the stress hormones, and actually recovery hormones, life hormones. Sleep, yes. So when you're starting to get sort of exhausted and hyper stressed, a lot of times the adrenals can get affected. These are the four phases that we say of adrenal issues of this sort of burnout. It actually starts with this sort of diva here on the far left. You're sort of wired for sound. Your cortisol levels are often high, and then neurotransmitters in your brain, other types of hormones in your brain, are also high.
Mm-hmm.
From there, you can be kind of wired and tired, these sort of two in the middle. Wired and tired, you can either have high cortisol, that stress hormone, and low neurotransmitters, or sort of the inverse there. It's really common to see people allergic, kind of infected, and then sometimes they'll be inflamed and in pain. There's sort of a combination of those two in the middle.
Like, and when you say infected, you mean?
Oh, excuse me, having frequent colds and flus, easy,
Like, you feel
just
like you're
constantly
so run
sick.
down, you're
Yeah,
always
always
sick,
Mhm.
you never quite shake it. It's that like respiratory, that upper respiratory infection that lasts the whole winter kind of a thing.
Yeah. And that often can be from this burnout, from
Mhm.
the fact that the adrenal glands are not secreting hormone when and where they should and the right way. And then finally, if you just are under a lot of stress for a long period of time, then you're just flat out, everything is just low. So know that there can be an adrenal issue, and start off again here to the far left. You can just be kind of wired for sound. That's like the beginning. It's the hallmark of the beginning of the process, and then it sort of moves its way generally through these things.
Mm-hmm.
So cortisol being the main hormone that we tend to look at when it comes to the adrenals, we can test for this very specifically, and it's a salivary test. So it's very uninvasive. It's something, a kit you would take at home, and you would spit into these little vials multiple times throughout the day into the evening. And then we would see where your circadian rhythm is, your rhythm of those cortisol levels, are they where they should be? You can see here in the morning, they should be nice and high. By the time you get to ready to go to bed, they should be low. And then in the middle of the night, they start to go up again, and that's what wakes you up. But it isn't always that way.
No, well, the problem is when we use phrases like when we're ready to go to bed, we have lots of patients. I'm sure if any of you out there understand that idea of, well, I'm a night owl. I'm not ready to go to bed until at least midnight. So when we're talking about adrenal health and the healthy cortisol rhythm, then we really want to think about the rhythm of the sun, which is essentially what that circadian rhythm is. So when the sun is coming up, that's when we should be having the highest production of cortisol. We should be bright-eyed, bushy-tailed, get ready to wake up. We may still be a little bit sleepy, but we should be, for the most part, ready to start the day. And as you're heading into the afternoon, that late afternoon, that's when we should start to have a natural decline of cortisol that will start to prep your body for sleep. That should happen between, I would say, 9 to 10 is the most typical time. We do have a question. And I don't know if we're jumping ahead, but
yeah, we so as far as the questions here, and it's great to see them, we're going to hold off to the end, and then we're going to try to answer them. But
okay,
you can start
good.
asking the questions
yes.
now, send them in right away. So DHEA, it's where cortisol is the stress hormone. DHEA is the anti-stress hormone. This is the one that's actually helping to repair you. I love this particular hormone because we use this both in men and women.
Mm-hmm.
We can do this orally as well as an injection. The injections are really, really fantastic to add on to a testosterone replacement therapy process and program. But you can see here, it's helping with your immune system. It's helping with weight management. It's helping with your heart. There's all kinds of research since the 1980s about DHEA helping with heart health, anti-cancer, great for your brain, energy, muscle, bone. And then one of the biggest things is it helps to manage stress. It is that, again, that anti-stress hormone. So here's growth hormone. Growth hormone, if you remember that little symbol there, it's that quintessential linchpin that kind of holds all of those together. And it's the longevity hormone for sure. It is a hormone that comes out of your pituitary gland. It secretes that. And then it does many, many things. You know, I liked this particular slide. IGF-1 is what you would look at in your blood work.
Because you're not measuring growth hormone directly.
Right. Yeah, growth hormone is constantly being produced, but it's kind of in and out of the system. And your body takes growth hormone and at the level of the liver, and it makes this thing there where it says IGF-1. So IGF-1 is what you would see in a blood test to be able to determine where your human growth hormone levels are at. And what we can see here is that right around 50 is when a lot of things happen, whether we're talking about estrogen and testosterone for men and women, or even growth hormone for men and women. A lot of things really start to become quite clinically significant at 50, even before that, but definitely at 50. So we can see the levels there for women, roughly about 150 and above, men 200 and above for that IGF-1 level. That's what we're looking for. Here's some of the benefits. Muscle, bone, of course. It's helping with brain and libido. It chills you out. Fine lines and wrinkles.
Yeah,
right?
I was going to say it's definitely involved in the aesthetics, all of that collagen and elastin, just preserving the youthfulness and the plumpness of our faces and body.
Yeah, for sure. Sagging skin as we age is one of the key signs. It's a hallmark of a lack of human growth hormone. So the more we can focus on that and keep those levels up, even at younger stages around 40 to 50, so where when we get 60, 70, 80, it's less of an issue.
I just want to take a minute to really say sagging skin. Like, it really starts to show up in places that you wouldn't expect, even though John says that I have a knack for putting myself in these ridiculous positions and saying, does this look weird? Does that look old? But little places around your elbow. I don't know.
Like the armpits.
Those are the kind of places where I think your growth hormone will really make a difference. Anyway, that's me. Go.
I don't really have those issues, at least that
No,
I'm worried
because
about.
it's worse for women than it is for
Okay,
men.
all right, okay.
Men will eventually have it, but women show these signs of aging. They do have more aggressive signs of aging earlier on.
Yeah.
And then I think they start to level off, and then men just start to get really old.
Is that what happens? Then they just...
I would believe that most women would agree with that.
Well, that's why we need things like growth hormone replacement. Yeah. So part of this growth hormone replacement can come in a couple different ways, and I'll pivot here about peptide therapy. Peptides are small little amino acids that some of those peptides can actually help you to stimulate your natural human growth hormone in your body. And then these are simple daily injections using a very, very small needle, minimal to virtually no side effects with this particular type of peptide therapy.
Mm-hmm. Just because as we age, there is a decline in growth hormone production, but there is also a more aggressive decline in how much gets released. So when you're working with the peptides, you're allowing your body to function more optimally on its own. And then you're just stimulating a more assertive release of that growth hormone that you're producing. So whenever you can work with the natural rhythms of the body, you're going to get way more benefit than any level of cost, right?
But whenever you can, absolutely. We're usually trying to boost the system to be able to do it as much as it can, help out where also we can or even need to, and put those two concepts together. Sometimes it's one or the other. Sometimes certain doctor approaches are just to only replace and they're not thinking about anything causal. Other times they're only trying to do 100% natural, and we like that, but sometimes it's not enough to give you everything you need. So you have to put those things together and work with the person in front of you. So CJC 1295, ipamorelin, tesamorelin, these are all natural growth hormone stimulation peptides. The other great one, since we're talking about peptides, is something called bremelanotide. And we offer all of these, by the way, at all of our locations. So bremelanotide is called PT141. It's the only FDA-approved medication for female sexual dysfunction. Men can use this for erections. Women can use it also for sexual dysfunction. Fantastic peptide.
So it's often referred to as the female Viagra. It does allow for more sexual sensitivity and an easier time of orgasm.
Yes. And it's a twice a week injection. Very, very simple. Again, very, very, very small little needle. You barely even notice you did it. Insulin and digestion. This is about that sort of weight loss concept too. We tend to treat quite a bit of insulin resistance or type 2 diabetes, and that's what this is about a little bit. This is also one of my favorite slides. It's one of my favorite concepts. And actually this 29.1 million people having pre-diabetes, it's going up. We're probably in and around 40 plus million, at least at this point. So 30, 40, 50 million people in the United States having some form of actual diabetes. The pre-diabetes, same thing, that says 86 million. It's more like 1 in 3 now. So probably around at least 100 million people having some type of pre-diabetic situation. But here's the big thing about it, that 9 out of 10 people don't know they have the pre-diabetes. That's always been the crazy stat for me,
Right.
that your blood work is off, but it's not off enough for your regular conventional doctor to think it's bad enough. And then they just say, you're fine. And you're not. You've got one step towards the whole diabetic situation.
And more importantly, you can still prevent it. That's one of the things that I hope you're all getting from these slides and this conversation, is the idea of just know where you're at. Like at whatever age, whether you're in your early 20s or you're already in your 70s, where are you at physiologically? How do those readings that your body can give us, like blood work or in office signs and measurements that we can take, what are they saying about your current state of health, so that you even know what you should be addressing?
Get tested, right? Get measured. What gets measured gets accomplished. And so we would be remiss if we did not talk about the GLP-1 agonists, these special medications that everybody's been talking about here in the past couple of years. I'd say quite a bit in the past 1 to 2 years. We've been prescribing it now for about 4. And we've just seen amazing results with semaglutide, also known as Ozempic, tirzepatide, Mounjaro. There's even a newer one called retatrutide that we're already kind of always on the cutting edge and looking forward to the next types of these GLP-1s. But they're really fantastic. They help your pancreas to release more insulin. This helps to keep your blood sugar down. It's preventing your liver from also releasing too much sugar. One of the biggest things, it's slowing down how fast food is moving through your entire GI system. That helps to keep you full longer. That also can be one of the reasons why you might see some side effects from these medications, because the side effects are certainly real. You can get constipation and or diarrhea. You can certainly get some nausea from these medications, right. But they work.
They work really well, and they work really well if they're being, if the patient is being assessed correctly and then being guided correctly. So there's a lot of, you know how we make medications in pop culture, we make these medications, these like heroes, and then we make them these villains. And the reality is that it's neither of those things. It's a tool, and it's a very good tool. And it just depends on how you use it. If you're going to be using these GLP-1 medications and you're not going to pay attention to how often you're eating or what you're eating, and you're not going to take an opportunity to really change your lifestyle to match a person with an elevated healthy metabolism, then it's not going to get you the permanent results that you should be getting from these medications, right?
Yeah, I think one of the biggest things with this is muscle, and we've done multitude of videos and discussions about the use of this particular group of medications. You got to maintain your muscle.
Right.
And whenever you're hearing that sort of nonsense out there about these medications and the side effects from it, when I say nonsense, meaning sometimes it's just more than what it actually is, but a lot of times it is true. But anyway, you'll hear people losing a lot of muscle.
Right.
And they get that, so what do they call it, Ozempic face and whatever. I mean, and it's true, but it isn't because of the medication. It's how it's being used and how there's a lack of monitoring going on from the
Right.
provider and the patient, and there's not an understanding. So we have patients who gain muscle when they're on this medication. Not necessarily, or at the barest minimum, they maintain their muscle and they're just losing fat.
Right.
We always say we don't want weight loss, we want fat loss.
Right.
So know that is possible when it's being used correctly by one of our trained
And we do have a
doctors.
whole podcast episode on this, just because it is a topic that so many patients ask us about. So we love talking about it. There's more information out there if you ever want a little bit more in depth.
So sex hormones, I think for a lot of people, this might be a main motivating reason as to why you would look at this particular topic and check us out on this webinar. These are, the estrogen and the testosterone, the issue of having low T, menopause, perimenopause. That's the big issue usually when we're thinking about hormones. We just kind of explained all those other ones to say that there's a lot of other hormones aside from just estrogen and testosterone.
And that they work together.
Yes, very much so. And that one is helping the other. So sometimes somebody thinks they have a thyroid issue. It isn't. They have a sex hormone issue, or vice versa. So you have to look at the whole thing and be able to have someone that really understands how to pivot in any direction.
They work very synergistically together. So if we're really trying to seek optimal metabolism and you're wanting to use one hormone, I would caution and say, if you haven't had all the other hormones evaluated, then be careful bullying around one system too much, when you may get much better results, or you will get much better results if the rest of the body and hormone systems have been evaluated.
So
sex hormones.
Sex hormones,
Woo-hoo.
women, the issues that we tend to think of, the hot flash, night sweat, mood swings, irritability, issues with your periods, heavy periods, light periods, not having periods, multiple periods in a particular month. Things just start to shift and change.
Mhm.
The fatigue, vaginal dryness. And, it's important to note that osteoporosis, diabetes, and cardiovascular disease, these three diseases are the diseases of aging in general, certainly of a lack of hormone for women, and the same thing would actually apply to guys. Women have testosterone. They actually have more testosterone in their body than they do estrogen. I know that's kind of strange. We don't tend to think about it that way, but women do, and they need it for the same exact reasons men need it, but they just need a little bit less in comparison to guys. But again, women need testosterone. It's extremely important.
And they need it well past their reproduction years, if not more so.
Let's say it's probably even more important at that point. We've had I have a patient who's she'll be 95, and she's on testosterone. I don't give her any estrogen. I just give her testosterone because that's the thing that helps her the most. So it's really a major impact. Libido, memory, focus, anxiety, depression, mood swings, irritability, muscle aches and pains, certainly muscle growth, metabolism,
brain protection,
brain
mood protection, bone building.
Yeah. Incontinence. A lot of times it's about strengthening the structures of the vulva to be able to help with that whole coughing, laughing, sneezing situation that you get when the urine's leaking out. If you can strengthen everything, and that's what testosterone and DHEA does for a woman and the vulva. So guys, of course, we know, I think we hear this more and more. Guys are understanding that they have hormonal issues and that it's about testosterone. Again, we've been doing this for 18 years. Early on, I'd say it was less. They were just starting to talk about low T with guys around that time. Now we understand it more. It's far more accepted and understood. And it's good for guys because they are having these issues and they need to be open.
They're speaking up about it, thank goodness.
Yep. So what are some of those symptoms? Same thing. I think one of the biggest things with guys is motivation. Guys need to sort of feel stimulated, and testosterone is a big, big part of that. For them. But, the same thing, the fatigue, libido. Libido means I want to. So the psychological desire and drive to want to have sex, it can just go down. I just don't feel like it. Or sometimes it's a functionality situation, and then there's erectile dysfunction. The first place for a guy, if he's having any kind of sexual wellness type of issues, then you definitely want to make sure you are checking out testosterone first, using that as a foundation. So here's the deal again, that, I circled 50 there in this particular slide, because that's where we will start to see a significant, not just decline, because you can see the decline was already happening even after the age of 20, but where it really becomes clinically significant for guys right around 40s, 50s is where he's really going to notice.
And for women as well, 50.
Yeah, it's 50. It's just this sort of magic age for a lot of people, right where these hormonal issues become a real issue. There were probably things that were happening prior to that, but once you hit to 50, it's that much more obvious. So for guys, we're looking for the range to be around 700 to 1100. These are optimal ranges. You'd notice that the range could be between 200, as low as 200, all the way up to about 1100, depending on the lab. So you could have a 201 and the doctor says, well, you're in the range. It's on the low end, but you're fine. You wouldn't be fine at all if you were down there.
If you have symptoms.
This is true. This is true. And most guys at that point would start having symptoms. In fact, this slide kind of shows us for both men and women about what testosterone, how it starts to affect not just symptomatically, but what's happening with the body itself as the levels start to come down over time. So more and more disease starts to kind of kick in. And, we can see as we get down really, really low there, erectile dysfunction, complete loss of libido. There's all kinds of heart issues that really, really start to kick in as testosterone levels start to go down. You can see the levels here for women are roughly about 1/10 of a guy. So women produce 1/10 of a guy. So the levels roughly are about 1/10.
I think this is such a great slide because it really gives you a sense of, I have so many women that will come in and their testosterone is a 30. And again, what other doctor aside from us are going to be looking at that and thinking, gosh, maybe the testosterone is why you're moody and you're having hair loss, and maybe it's why you're having acne and you have no libido, etc. Look at the range above that 30 on this slide. Look at all the conditions that are related to testosterone being less than that number. That's a very important point.
Mhm.
So again, get tested and then speak up.
Excellent. Okay, what else we got? So hormone pellets. So now we want to talk about how we're going to you want to get hormone in the system. You want to replace it. What's one of the best ways to do it?
This might be one of the questions on our list today. So
yeah, for sure. So definitely pellets are the way to go in most cases, usually for women, but not always.
Right.
So what is it? Small little hormone pellets. You can see how small it is. It's about the size of a grain of rice. We numb a little area on the side of the hip. We make a small little incision you don't feel. And then we use this hollow sort of pen to place the pellets under the skin into this sort of fatty tissue area you see here. Super consistent, set it and forget it. And it lasts 3, sometimes up to 6 months.
Yeah, it's great.
Here's all of the hormone kind of treatments that we do, in most of them anyway, all in one spot. So when we talk about hormone replacement therapy for men and women, we're talking about all of these things. But particularly for you guys out there that are watching, it's not just about TRT, it's about hormone replacement therapy. Testosterone replacement therapy is only one aspect of it. So we would add in DHEA. There's another fantastic hormone that both men and women can use called nandrolone. Here you're seeing one of the types of peptides. It's called sermorelin down there at the bottom left. That's all for growth hormone enhancement. And then actual growth hormone called omnitrope. So we're looking at this fully in a comprehensive, holistic way to where it's not just one thing, like here's some testosterone, you're fine, or just here's a little bit of estrogen, you're fine. We're looking at the whole thing. We're not necessarily doing all of these things, but we're considering all of them. If you're going to do an injection, and we have really discovered this, and probably now over the past maybe 8-9 years, we have really figured out this way to give hormone for both men and women. And
it's great.
It is fantastic. It keeps the levels very consistent. So there's injections. Maybe guys have heard testosterone injections, but they usually think about it as an intramuscular injection, maybe going into the leg or into the butt. And this is actually going into the fat, but into the stomach. And it's smaller amounts, more frequently. It's so convenient. And women actually only have to inject once a week. Guys will inject twice a week.
Mm-hmm. Most patients just self-administer.
Yes. So yeah, we give you everything and then you take it home. It's just a fantastic way to do it. So, obviously we're always thinking and talking about sex. When we're talking about orgasm, sexual arousal, just in general, we're looking at it in 3 different ways. We're looking at it from the tissue standpoint. We're looking at it from making sure your hormones are balanced. That's largely what we're talking about today. And then also sort of the hormones of the brain. And we're looking at it at all those levels. Sometimes we have to attack one or the other. Sometimes we are addressing all 3. But know that sometimes you have to approach it in different ways. And we have solutions for all of these different ways. So testosterone, estrogen, there's also a hormone called oxytocin. Prolactin, we measure those levels as well. Dopamine, melanin, serotonin, these will all affect libido and arousal. And then sometimes, and many times actually, the tissue itself, whether the penis or the structures of the vagina, just aren't functioning the way they otherwise could. And there's actual natural procedural things that can be done in a very simple way.
They're extremely effective.
Well, speak of which, the O shot. So the orgasm shot for women, we are using platelet-rich plasma. And that's what it's saying over here on the right-hand side, PRP. This is coming from your own blood. It's all 100% natural. The growth factors from your own blood. And then after you are numbed up extremely well, really well, right? 3 times over, there's a cream, there's ice, and then there's actual anesthetic. So you're very, very numb by the time we actually do the procedure. And it's placed into the anterior vaginal wall, which is sort of that G-spot area, and then into the clitoris. And this is helping with arousal. It's helping with just overall functionality, secretion, lubrication. It's pretty cool how this one works. Very, very simple to do. And then, of course, the P shot. So we're taking that same platelet-rich plasma, and we're just strategically injecting that also into the penis after a guy is extremely numbed up. And not only will it help with erections and laying down new blood and nerve growth, but you're also getting a little bit of increase in length and girth. So that's usually when the guys say, "Where do I sign?" Again, as a reminder, all of our locations where we're at, literally now at this point, coast to coast, because from all the way from California to Florida and places in between, know that you've got all of these kind of answers at all of these locations. And hopefully either one of us can see you, but again, we have physicians that we have personally trained into these random systems that are not quite so random now. Now we can move on to the questions. Let's see. I've got a question here. Let's start with Christy. Christy's been very helpful here from the very beginning. Christy's saying she's going to be a new patient coming in to Livermore, California, there at Sculpt. And it was a good intro for you, Christy. I'm glad that that worked. And she's saying that her labs already show low testosterone, and she's wondering if you only look to shots or pellets or creams as well. That's a really, really fantastic question.
Mm-hmm.
So there's many different ways to put hormone in the system. There's pellets. We talked about that.
Sex hormones.
Sex hormones. Yes. Thank you. Estrogen and testosterone. We can do pellets. We can do injections. There's creams. There's gels. There's patches. And there's oral forms. And what we have found over the years is that creams, gels, these things tend to not really keep the levels consistent. I think that's the biggest
thing. I'll speak for myself, although I think you and I agree. The only time I find creams really useful is if I'm using a local cream, usually around the genitalia. And that's maybe for atrophy of tissue, or sometimes the person has some sort of an autoimmune skin irritation in the genitalia, in which case localizing the cream is helpful. But if what we're really looking for is that overall systemic benefit that HRT is so great for, that sex HRT is so great for, I really don't rely on creams.
Yeah. What happens with creams, I always say your skin is designed to absorb, but your skin is also very much designed to repel. So what happens is over time, you get a receptor site insensitivity. That means that the ability for anything to be absorbed, in this case, the estrogen or testosterone, it can't penetrate anymore. And so patients will say, yeah, maybe the first 3 to 6 months I felt pretty good, and then all of a sudden it just stopped working.
Right.
And because it's not actually getting into the system. Plus, aside from that, the levels on the labs just, I don't know, say that it just
and compliance isn't as good, and transference onto other people is there. There's a lot of reasons why we think that creams are just not that great.
Yeah. With all of that said, we're always very open. So we meet the patient where they're at.
Mm-hmm.
So some patients come in and then maybe they have distinct reasons why they're wanting a certain thing. We'll educate and inform as to what our recommendations would be, and then we launch the ship from there. But generally speaking, we really think that the pellets or the injections are a fantastic, consistent way to put hormone in the system.
Yeah.
So what else? We have another patient here who said that she has had breast cancer. Is she able to start hormone replacement therapy? Really, really good question. If you have a history of breast cancer, we'd have to kind of, first of all, know what type of breast cancer it was. You can have certain types of breast cancer that are not actually responsive to estrogen, meaning estrogen didn't influence that breast cancer. And if it didn't, then it wouldn't matter one way or another. If, however, it's an estrogen sensitive breast cancer, then at that point, we're usually suggesting that a patient would not do estrogen at that point. However, testosterone, and there's plenty of research behind this, testosterone is actually beneficial for women who've had breast cancer, and it does not increase the risk for future breast cancer. If anything, it literally reverses that and prevents that reoccurrence of breast cancer for women who are actually on testosterone. Again, a lot of research that's aside from 18 years of working with breast cancer patients. There's a lot of research behind what I just said.
And we, of course, work very closely with the oncology team when indicated. We communicate. We work with other practitioners for many different things, but especially when we're talking about HRT and the history of cancer. And that's true for men with with prostate cancer as well.
Well, that was another question that we had up here about.
About the prostate
the
cancer.
prostate cancer.
You know, it's just, it also will be, the patient will say, my quality of life is so impaired being off of my hormone replacement that I have to take that into consideration as well when I'm making decisions about what I should and shouldn't do after having had cancer.
You know, it's interesting. I just relatively recently had a conversation with a patient who developed breast cancer. And I, of course, took her off the estrogen. She's worked with her team. She's very, very sort of natural minded in her approach. And just was, again, not that long ago, having a conversation with her where she's had different scans and she's kind of let a certain amount of time go by. And she's now saying that she is ready to start estrogen. Now, in her particular case, there is a level of risk there. We've discussed that risk together now for many, many months. And she's ready to move forward because in her particular case, it's a quality of life situation where the only thing that was helping with her headaches before she ever came to see me was estrogen. And then when I started helping her, the estrogen is what was helping her headaches. So now that she hasn't had estrogen for, I don't know, it's been a couple of years now, it's just been debilitating for her. So she's making that decision, a very informed decision about moving forward for sure. So
I think that the take home message, hopefully for all of you, is that you're an individual case. So in medicine, we do absolutely, like in many fields, but in medicine, we do absolutely rely on experiences before us. What does the literature say, etc. All of that is very important. But at the end of the day, we have to ask the patient, what do you think and what do you feel? And that may be one of the most important tools that we have as doctors in helping to guide you towards the right treatment choices for you.
You know, another comment. Thanks, Christy. Really appreciate it. Look forward to meeting you. She's saying here that she doesn't really have libido issues, but her OBGYN told her after her hysterectomy to, quote, have my husband wash the dishes more and you'll want it more. Yeah.
I mean, it's not bad advice if like your girlfriend is giving it to you over coffee, but I don't know that it's the best medical advice. But you know what?
We believe.
I have patients come in all the time that tell me, my doctor said if I get Botox and a breast lift or whatever, that I won't be depressed anymore. And I'm like, or you're subclinical hypothyroid, even though your labs say that you're fine and your testosterone is low. Like, come on. Yeah, these lifestyle interactions in our relationships and couples, it's part of the reason why John and I talk about this so much. If we don't feel well, it's a good idea to evaluate how is your relationship. But it's not the only thing. It's a good idea to look in the mirror and say, do I still feel beautiful? But it's not the only thing, you know? So, oh God.
Yeah, you know, these doctors.
Well,
it's such a flippant sort of answer, and you know, maybe he or she was trying to be, you know, joking around. I don't know, but
I'd like to give him benefit of the doubt. But we've heard some jerky stories.
Exactly, and it's usually they say these kind of things because they actually don't have any answers. So when often doctors are trained to say that you have all the answers, and what isn't the answer, then it's all in their head. Yeah. It kind of defaults to that.
Instead of just saying, I don't know.
Yeah, I don't know. Let's explore this. Let's figure it out.
Let's look it up.
Maybe someone else has the answer.
I mean, we're functional medicine doctors that have been, and I say this a lot, but humility aside, we're very good at what we do. We've been focused at this our entire medical career. We put hours and hours of study, and we have thousands and thousands of patients. And guess what? We often get stumped. So that's why I say it's an individual case. You have to be willing to explore, and patients have to be willing to explore. That's the other thing. Remember, for all of you out there listening, you're responsible for that as well.
And don't take no for an answer and keep looking.
But also don't take the pill as an answer. Sometimes the pill's not the right answer, or it's not the only answer. Anyway, what else? We had
there's another question here.
Time for another question?
Yeah, we do.
Okay.
So is the O shot painful? Also a great question.
I'm going to go with a yes.
Well, again, we have done it many times where it is not painful and there's barely any sort of notice to what's going on. But I think it very much can be.
Fine. I will. Okay. I always like to give the story about I've birthed 3 girls, and all 3
I
were
have not.
with natural labor. They were not with any sort of pain intervention for personal reasons. Okay. But I remember when we were learning hypnobirthing,
Mhm.
and they said, childbirth isn't painful, it's just pressure. And for the first baby, I really went into believing that it was just going to be pressure. And here's what I say to that: it's not true. It actually hurts a lot, and there's a lot of pressure. So the O shot, PRP in your face. So not just whether, because remember the PRP you're using on the penis, you're using it in the female genitalia, you're using it in the face. Like PRP is just awesome. We use it for hair restoration. So does it hurt? The PRP itself has a level of acidity that makes it sting the tissue a bit. Now, pain is very subjective and there's a spectrum. So I would say that yes, the O shot hurts. Do I think it hurts so much that it's not worth it? No, I've had it done twice with like a 6-year difference just because I had my last baby so late. So Dr. Robinson is correct. The better you are at the technique, and we're very experienced, we're very good at doing it, I think the less discomfort patients feel. But as a patient, I would still say it hurts.
Well, I will say this too. We're both patients because when we went and learned how to do this, we ran right home, and she did a P shot on me and I did an O shot on her.
When we were like our first patients.
Yeah. So I will admit my technique was not great that
No,
very
it's
first
gone
time
way-
around. Yeah. So sometimes you might be referencing your own personal experience with me not being quite on my game, whatever,
Yeah.
9 years ago.
Either way, I know that the right answer is the least subjective answer. I think the right answer here to say is there's discomfort associated with the procedure for women. I would say more so than men, right? I don't think the men complain about it.
They just don't.
They
And
don't.
that's because there's more space there. The men, the penis, as I say, is a double barrel shotgun, so it's going into a space.
Right.
Where with women, it's more of a
It's more
compressed.
tight.
Yeah.
But I think whatever discomfort patients have experienced from the O shot, the reason it's such a popular procedure is because it ends up being worth it. Just like having babies, they're worth it.
Mhm.
All right, what else?
We got a last question here. Does hormone therapy change fertility levels in women? And we could even expand that to say,
and men.
and men.
Yeah.
Does it affect
Good question.
men? I'll start with guys first. The answer is yes. For men, testosterone can decrease the ability for sperm to be produced. So if a guy is young, but yet his testosterone's low and he's still thinking about a family, then that is one of the risks, and that has to be considered. And we have ways of sort of handling that throughout the process, cycling the guy on and off. We use certain things like clomiphene, that is a medication that tells the testicles to continue to make sperm. So there's ways to handle that situation very strategically for a guy, to where you can still get some of that benefit from the testosterone, but at the same time, don't put his testicles into a situation where it's not producing sperm correctly. For women,
I would say that all the hormones affect fertility, not just the sex hormones. The number one thing that I do with a female when we're working with preconception is I make sure that we do a very generalized metabolic evaluation. I would say that females that have had a hard time conceiving, and mind you, according to medicine, a hard time conceiving is that you've gone at least a year without successful conception. I would argue that for the patient, if they go 3 months without successful conception, they start to get worried. And I think it's wise not to be worried, but I think it's wise to be proactive. So if you've had 3 months without successful conception, then don't feel that you're a candidate for fertility treatment, but do start to ask yourself, am I prepared to be the best vessel to receive and grow a healthy pregnancy? So after 3 months, I would say consider preconception metabolic assessment and look at all of the hormones, because the thyroid, low testosterone, and definitely insulin resistance are going to be 3 of the primary systems I see making it hard for my ladies to get pregnant.
So I think that is it for now.
Mhm.
We really want to thank everybody for
Yeah.
coming. We're going to do this ongoing. So if you know of friends and family that are wanting to understand more about hormones and other things related to longevity and health, know that we're going to be doing webinars on a regular basis. We, of course, like we said, have the longevity protocol and all the other things that we do in all of our social channels, et cetera. There's a lot of information out there for you, and to hopefully subscribe and share. Anything else?
No, just that. We thank you so much for the support. This is really our love and our passion. So we're happy to have an audience to speak to. And of course, your support in promoting our channel and promoting our podcast just makes it easier for us to keep doing what we're doing.
Absolutely.
So
It
thank
spreads
you.
the good word. Yeah. Thank you. We'll see you again. How do I do this? What do I do? Is it over?
Goodbye. Goodbye.
Do I hit that button? This button?
Yes.
End session. Bye.